Good afternoon, everyone. I am Dr. Nupur, Senior Consultant in Artemis Hospital. And the topic that today we have for discussion is the nursing care and the role of nursing care in end-of-life situations. So, as we all know, since the last decade or so, the longevity of our people has increased. And many patients, you will find they have terminal illnesses. And because of the advanced medical practices, they are living more. However, often we have in our patients that we encounter that they require end-of-life care. I mean, since a nurse is the one who is the most one-to-one in contact with these patients, the role of nursing in identifying and implementing end-of-life care is paramount. So, to talk more in detail about this topic, let me welcome Dr. Manish Bharti. He's an Associate Director and Head in the Department of Critical Care Medicine, Indian Spinal Centers, Delhi. Sir has multiple accolades under his name. He has been awarded the President Citation Award by ICCM in 24, as well as the Promising Intensivist Award by Times Now. He is also an honorary advisor of resuscitation practices to the Cardiac Center Sultan in Saudi Arabia. Welcome, sir. Very well.
Thank you, Dr. Nupur, for such an extraordinary introduction. At the outset, I would like to wish everybody a very good afternoon, very good evening for giving your time and space to this activity. At the outset, I would also like to express my gratitude to Dr. Jitendra Sharma, who has been one of the closest and one of the best mentors for the education program. And he has made a lot of contribution when it comes to the ICCM activity. So my topic of presentation for the next, I think 45 minutes, Dr. Nupur, it's going to be, as you have very wisely said, the nursing care in the end-of-life situation, right? And I begin my presentation with the greetings from the Lord Krishna, Hare Krishna. So the topic which we are going to explore is nursing care in end of life, right? This is what we are going to speak. Now, the very first thing which I want to ask to all the residents or all the nurses and all the participants in this activity, and maybe Dr. Nupur to you as well, that what would you do or say, let's say that you're going to get into the room where the patient is going to be scheduled for his or her medication, and they just tell you at the outset that I have left with only 2 weeks. I'm going to die. So how would you respond to this given situation? Or how would you react to this given situation? Do we have seen this kind of a situation to the nurses? So maybe the people can, if anybody would like to share their experience.
Anyone would like to come up with that?
Yeah. So ये बहुत very commonly होता है, you know. Let's say I'm going inside the room to give the treatment to the patient, and suddenly the patient is saying something which stuns us, which gives us more of a startling response. कि मुझे क्या करना है, मैं किसमें क्या respond दूँ? So it's very difficult at times to even understand that how should we respond to this given situation. To understand it better, what we did in-house survey in the Indian Spinal Injury Center. It's one of the biggest palliation care units which we are having in Delhi NCR for the trauma cases. So we recruited 64 nurses, and out of those 64 nurses, almost 42, which means 65, major subset, they said that we don't know how to respond to this question. Big number, right? And 10 out of them, they were agreeing to talk, but they were very uncomfortable because they don't know the right answer. It's only 6 out of the 64 number, just 10%, very small subset. They felt very comfortable in answering. And the 6 nurses, they didn't participate. Now, what I wanted to stress upon through this slide, that almost 90% of them, they don't know how to either give the right approach to this given situation, or maybe even if they want to respond to the situation, they don't know whether they are doing right or wrong. So that is the magnitude of problem which the nurses are going to face, or be it any other healthcare provider, which is going to face when they're going to deal with the patient who is going to die, right? And the recent study, especially if you go although it's not a recent paper, but It's a very important paper on approaching death and improving care at the end of life, which got published in 1997, where they said only 1 in 4 nurses, they feel confident in caring for dying patients and their families. And to add the misery onto this given situation, if you go by all the nursing textbooks, only 2% of the data in the nursing text is related to the end of life care. As you said, Dr. Nupur, that now we have more longevity, the people are more living. But this issue seems to be very much unaddressed. I would like to acknowledge that, majority of the part of my presentation would be pertaining from this text, which is on nursing care at the end of life by Suzanne E. Lovey, where she has given the beautiful clinical aspects of the nursing care at the end of life and what every clinician should know. And I would encourage each one of you who is participating in this activity. It's a free PDF file. Maybe I can upload in the Zoom activity as well. You must go and explore this data, that how you should face when somebody is going to die, right? Now, it's very important. Unless and until I know the gaps, how can I close the gaps? So we understood that somewhere, we as a healthcare providers, and majority of the time, the nurses, which are basically the frontline warriors, it is them who are going to handle the situation. Just to get into the further insight, we realized, and this is the data from the West, that the nurses have been extremely good when it comes to the technical skills, administration of IV injection, insertion of catheters. So these are all the essential part of their training in the nursing curriculum. But the greatest part of the treatment in end-of-life care and even the palliative care is by providing the effective human and communication skill, for which there has been the least practice skill, and this has been the least in terms of their teaching curriculum. Just imagine the palliative care and the end-of-life care, which we are going to explore how they are different and how they are together. They need the maximum contribution from you to provide the effective human touch and for you to communicate. And we will understand what aspects of communication are important for the nurses to acquire upon. So let's talk about end-of-life care. And I'm sure you are going to deal with the patient who is going to die, if not today, then maybe tomorrow. So nursing care, it has 2 major components which we spoke, the nursing care and end-of-life. Now, what do you mean by a nurse? So I went into the very basic definition through the Cleveland Clinic. And what they have said, the nurse is basically a trained professional who provides the compassionate, patient-centric care. Now, this term compassionate is very important to explore. So the compassionate means that you are very sympathetic to the suffering of your fellow patients and you're doing something to alleviate their suffering. It's just not an awareness. You're also taking in steps to alleviate their suffering, and may not be just the pharmacological approach, but the multiple aspects and the multiple layers of healing which are important in end-of-life care. And now the second part, the end of life. So the end of life, if you really want to understand, you start from the metaphysical aspects of end of life. And when I went back and I started diving deep into this concept of death, the first thing which came to my mind is this book, which was written by Sadhguru. The book name is Death. And where he said the only truth which exists in the human life is either life or death. These are the only 2 constant truths. Rest, everything is a perspective. Rest, everything is an experience, right? And we are all preparing our life on day-to-day basis with so many challenges, with so many ambitions, with so many, the good things we want to achieve in our life. But we also must prepare well when it comes to the death. And this is where we are lacking in medical science, right? And if you read this paper, which is given in the Scandinavian Journal of Caring Sciences in 2018, they have clearly, explicitly expressed that life and death are mutually complementary concepts. So please don't disconnect them. They have to be seen together. The death is something which is going to be inevitable reality for us and will be experienced by every individual. So there's no point to defeat this as a process. And that's why every person who is a human deserves the death whenever it happens to them with the dignity, freedom from the pain, and making sure their mental, their spiritual, and their social aspects has been taken into the consideration. This paper on end of life is a brief review, which you can go to understand the synopsis related to the end of life care. And what they have said, end of life care is a highly personalized, which means every patient is different. You have to tailor-make the EOL care when it comes to the patient A versus patient B versus patient C. Every patient is different. You have to tailor-make, right? Everybody has a different requirement in terms of their physical pain, their mental agony, or their social imbalances, or their spiritual concept. You have to be compassionate. As I said, you should be having an intent to elevate their suffering. And that places a high value on patients and their family's comfort, respect, and dignity. So what is very important, you're just not treating the patient in this given situation. You're also taking care of the family, the loved one, the next of kin. And just remember this definition. There's nothing we are doing pharmacological in this part. We're taking care of their comfort, respect, and dignity. These are all human values. These are all human skills we are talking about, right? Now, the end of life care has 4 major components. It's the wheel of human life, which basically divides on spiritual, physical, mental, and emotional. We are expert as nurses, as doctor, to take care of the physical aspects. But what is being neglected is the emotional, the mental, or the spiritual well-being, right? So the patients who are basically end of life, near to death, are basically the patients, you know that they are not going to respond to any curative treatment. So they are having almost a terminal illness, right? Like the patients who are having a cancers, the patients who have a terminal heart failures, you know. So we are not doing anything aggressively to treat the disease in EOL. But what we are focusing on is basically the elevation of their symptoms. So we're working on symptoms. And of course, we provide the holistic support to the physical, emotional, social, and spiritual well-being for both the patients and their family. As far as the physical aspect is considered, which we feel that we are an expert, is to control the pain and the symptoms. Now remember this thing, when you're controlling the pain and the symptoms, not necessarily you're treating the disease. It's basically the symptoms which you're just focusing on. And of course, end of life care may include the palliative care, supportive, and hospice care, which I'm going to unfold in the next 2 slides. So my dear friends, my dear nurses, my dear healthcare providers, end of life care is not to prolong life. We don't focus on prolonging the life. We focus on preventing or alleviating the pain, which I spoke, while respecting the dying individual wishes. It increases the individual quality of life so that the person who is going to die should see himself or herself as honorable and peaceful in the last stages. Just to give you an overview, the trends in the death and dying patients, if you go from CDC 2011 data, majority of them, they are having a chronic illnesses like heart disease, cancer, chronic lung disease, stroke accident. So basically the chronic disease, they supersedes the infectious diseases like your pneumonia or any other infection. That is the major burden. So these are the patients which you're going to see when you're actually going to see the patients with end of life care. Now, very commonly, you will get confused between these terms which are known as palliative care, hospice, or end of life care, or the bereavement. To make it a better understanding of this, try to understand this, the diagram which I have shown you. So basically, when the person developed any disease, right, you started working on to the curative part of their illness. But remember this thing, when you're working on to the curative, which means the treatment which is related to the cure of the disease. Let's say the patient has heart failure and you're working on a heart failure treatment. Simultaneously, you're also working on to the symptomatic management. So which means you will ease out their dyspnea. You will allay their anxiety. And this starts simultaneously from the point when there is an inception of the illness. And that is what is meaning by the palliative care. So palliative care is not necessarily for the end of life care. It just means that the patient is having a life-threatening, serious illness where the recovery may or may not be possible, but you're making them comfortable in terms of their physical symptoms, in terms of their mental agony, in terms of their spiritual and social upliftment, right? Now, if the disease doesn't cure, for example, it eventually reaches to a stage which is known as hospice or the end of life care. Now, when I say the word hospice, it means there is a dedicated facility where these kind of patients, they can stay and they can be treated as a cohort in terms of the holistic aspects of the care. But if he loses the patient by any means, there is a process of grief and the grief reaction, which the nurse should be able to embrace for their patients and their family, and it's known as a bereavement process. This entire spectrum is a part of palliative care, right? To go and make you understand further, in palliative care, the patient is serious, but not necessarily the patient is going to die. But in hospice, when we say it's basically the end of life care, where the patient is diseased to an extent that the disease is terminal, we know they are going to die. Generally, when we talk about hospice care, it's basically the 6 months final, which they are going to have there in life. While palliation starts right from the inception of the disease, but it can be any time. In case if you're not doing it in the first, it should be started as early as possible. My dear nurses, please don't confuse palliative care with the end of life care. And I'm sure Dr. Nupur is going to ask certain portion related to it. As far as the treatment is considered, the hospice care is all about the pain management, the symptomatic treatment. Remember this thing, you are not going to invest anything onto the curative part. You are not doing anything to cure because we know we cannot cure the disease. But in palliation, you're working on pain and the curative both. Both can be given anywhere, there's no doubt. And as we said, this is not going to be a one-man effort. It's a multidisciplinary support. So we have to be together to treat them together, right? When I say multidisciplinary team support, I stand here. Me and Dr. Nupur stand as a doctor. So we are taking care of their pain. We prescribe them pain medications. And of course, we have to first know and learn how to assess the pain, which you also supposed to know as a nurse. But when it comes to you as a nurse, who are basically the frontline warriors, you are the people who are going to be in maximum touch with these patients. Your one-to-one ratio interaction is going to either enhance or is going to fail the end of life care program which we want to achieve. The physiotherapists and occupational therapists, they plays a very important role when it comes to improving their agility, to improve the qualities of their daily living. The pharmacists help us in organizing the medication. The social workers and the psychologists work on the individual perception of the disease and what they need to feel better. The chaplains or the spiritual enthusiast, which I feel is very important. I am a dedicated devotee for ISKCON. And let me tell you, through my understanding, my spiritual journey, that as long as you are spiritually connected, it's very easy for you to depend upon. There are a lot of things which are going to be beyond us. And that's why the patients, like the EOL patients who are going to die, they need certain anchor. They need certain reference so that they can feel better. So as we have discussed, the hospice care is a part of palliative care, but not every palliative care is hospice care, right? And end of life care is the part when the patients are actually going to die. Now, if I have to just revise and reiterate that what role you are going to play as a nurse. Nurses are the primary provider of end of life care. Whatever I do, whatever Dr. Nupur do, and whatever Dr. Jitendra will advise, eventually it is you, the nurses, in one-to-one ratio interaction who is going to provide this care. Nurses stay with the patients for the longest time. And that's why they have the highest potential to influence the disease outcome. They are the first people who will understand whether the patient is responding to the treatment or not. And that can help us as a clinician to decide if the patient needs any reframing or the redirection of the treatment. They will help us to understand the preferences of the patient and the family, right? And they are the one who serve as the foundation to bring the patients, the family, the doctors together. And that is why they are very important. They have a very important role. When the patient is failing from the palliative care to, let's say, the end of life care, we know they are going to die. And it is basically the nurses which helps us in the transition from the treatment-oriented approach to the comfort-oriented approach, which means we are not going to focus on to the curative treatment at all. And the nurses, they provide our patients, our beloved human beings the comfort for whatever the time they have. They are the one who provide the necessary care and also the help to the family to cope up during this process. So end of life care has three major important paradigms. One is comfort. Remember this thing, we are not talking anything related to the pharmacological as of now. The first and foremost is comfort. And the best comfort happens through when you listen to them. And that's why it's very important skill which the nurses should be able to honor and should be able to harbor is to learn how to listen. So we call it as active listening. You listen with an intent to understand and you paraphrase their symptoms and signs, whatever they are saying. The second is information. Every patient has a right to know about their disease. And since the nurses who are available most for their interaction with the patients, so they have the first hands-on opportunity to ask this information directly to the nurse, right? And the nurse can better answer this situation if they're betterly prepared. So unless and until you as a nurse don't understand the end of life care, how can you tell them the tenets of the end of life care? And the third thing, the nurses also help in preparing the patients and the family for eventually the acceptance for the truth, which means they're going to die. Right? So it's basically the triad, the nurses, patient, and family relationship, which is being channelized by the nurses. And it's a patient-centric approach. And that's why all these three paradigms happen through the effective communication. When I was going into this, Dr. Nupur, and I was trying to explore that how do the nurses, they have been able to make an impact. And when I went into this, she's one of my favorite authors, the Bronnie Ward. And what she has said, she's basically a hospice nurse. And the impact which she has been able to bring in the people who are going to die is what she's trying to explore, is what she's trying to portray in this book. And through the deep interaction which she has been having with the patients who are going to die in this hospice care, she discovered the different layers of healing. She discovered the top bridge or the top regrets, what they have been having at the time when they were about to die. And I encourage each one of you to go through this text, which means that how the nurse can help you in learning the different layers of the healing. None of them, they said during this process that they were worried about the pain. Majority of them, they said, I wish I would have had the courage to live a life true to myself, which means congruence to their values, which was missing. How can I discover this unless and until somebody discovered this paradigm for us? Right? And they were the 5 top things which they have been able to describe, which I leave for you to explore so that you can serve your patients better. American Nurses Association in 2024 has given certain responsibilities to the nurses at the end of life care. And of course, what they have said, that every individual who's going to die, regardless of wherever they are, whether it's an ICU, palliation, or home, but they deserve to die with a dignity and peace in the death process. In case if you're missing on end of life care, it's a blotch on being a human. It's a taboo, I would call it as. Because if you're not practicing end of life care, these kind of cases or these kind of patients, they actually suffer from the pain. The physical pain is the biggest thing which we are talking about. And if they continue to experience the pain, they will have more physical and mental exhaustion. When there is a physical and mental exhaustion, these patients, they suffer from the lack of energy and clarity of thought. And nobody would like to see himself or herself as confused and not in a position to take the decision. And because they have lack of clarity, they cannot decide their own care and treatment. And this is where the biggest fallacy in being a human being lies, that their autonomy is lost. And that's why the pain is very important, right? When anybody is going to die, you as a nurse will go and witness these patients in different stages of dying, right? So there are 4 major stages, which are denial, anger, and the depression and acceptance. In between, the stage of bargaining also come. Now, these are different stages depending upon when you're going to meet your patients. Let's say that you gave any information that your patient is having a pancreatic cancer and your doctor has given this information. He's going to die, let's say in the span of a 6, he's having a terminal disease, having a bony myths, and these are the challenges. Now, when you're going to face this patient, the first thing which you will experience that they are going to be in a stage of denial, right? As a nurse, you can intervene. This, I won't say intervene, you can facilitate this stage to get less and less by being sensitive to the patient thoughts and ideas. Even if this sounds to be medically unrealistic, we don't have to reject. Idea is to just listen, just understand. It is the pain, it is the discomfort, it's the agony which speaks at this stage, right? So there's no need. You need to actively listen. There will be a phase when they will become anger and there will be an anguishness. In this stage, you will respond to the patient anger in an accepting but non-provoking manner, which means you will respond, but you will not react. And very important thing which we have seen, which we see as a fallacy, even in me for years, is that I used to take it personally when the patient used to be in anger and anguish. So please do not take it personally. It's the anger which speaks in the stage of anger. The third is the stage of depression, where the patients, they become less participative. But this is the stage where they will start understanding. The beginning of the understanding happens. So this is the time when you have to spend time with the family and educate them, make them understand, encourage the family to be supportive by the human-to-human interaction. And the last stage is the acceptance, where you continue to facilitate this journey. You give them more of a non-verbal communication. Not everything needs to be spoken. Sometimes we just need to learn to understand, to listen. Majority of the part of the communication, 55% communication, which anybody makes is through the non-verbal, which means by quietly sitting with the patient, holding their hands, stroking their back, and just asking what they need is very important. And all these things can be beautifully enacted by our nurses. So in the sick room, 10 cents worth of human understanding is equals to $10 worth of medical science. And that is what we are going to strike by being united in the nursing care. There are certain ethical concerns which we face in the end of life care situation. It's outside the purview of this presentation, but it's important for you to at least know the basic ethical concerns which you are going to face as a HCP, healthcare provider. So first we need to understand what do you mean by ethic. Ethics is a branch of philosophy that is focused on understanding the moral principles of people. We are basically talking about why and how and what they understand and how they make decisions based on what is considered morally right or wrong. So it's basically the philosophy, right? And why it is important, because when it comes to the context of end of life care, there are many challenges which you are going to face, especially the ethical dilemmas. And we can help not only the patients, but also the doctors and various healthcare providers in deciding the plan of care. There are 4 major principles: the autonomy, the beneficence, the non-maleficence, and the justice. What are them? Briefly, autonomy means the patient has a right to self-determine a course of action and to support the independent decision-making. This is very important. You have to respect the patient as an individual. Sometimes the patient maybe is not agreeing for a decision. Sometimes the patient may not be taking the right decision. And the nurse may feel that it is not the right decision which the patient is taking. But you, as an advocate for the patient rights, must support their decision. Right? You may not agree, but please do consider to support their decision. The act of beneficence means the principle of doing good and has been having 4 distinct parts. What are them? The first one, please do not do, or please not to inflict any evil or harm. Don't do any harm. The second is to prevent any evil or harm. The third is to remove if there is any evil or harm. And the fourth one is to do good or promote good. Now, these are very esoteric, which may sound to be, but if I have to give you an example, Let's say the patient who is going to die, and you as a nurse, is a bedside nurse, and tubing them is not a solution. So in that situation, tubing is not going to help them. You can always participate that tubing is potentially is going to harm them, right? So not to inflict, it's only going to prolong the misery in that given situation. So you can help not only the patient, but also the family and the healthcare provider in making a decision. The second is to prevent evil or harm. What the fun you will get by doing a tracheostomy for these patients, what the fun or what the agenda you will achieve in case if you are having a central venous catheter for them, right? Third, let's say the patient is to remove any evil or harm. Certain therapies are harming them. Polymyxins, AKI, the patient is not surviving. So you can consider for the de-escalation for them. And last but not the least, to do good or promote good. So when you are doing all these things and the patient is dying, the dying situation doesn't mean that your nursing care should die. That is, in fact, where your effort has to be maximum. Make them ambulate in case if it is possible. Give them all the human touch which anybody deserves of being a human. Non-maleficence is the principle of refraining from causing unnecessary harm, which means that if anything which you're doing should be having a moral justification attached to it. The justice is the principle that governs social fairness. Now, this is very important when I was in Middle East and UK, where you see that irrespective of sex, irrespective of caste, creed, religion, and the nationality, everybody deserves to be treated as equal. So you as a nurse should be the most important advocator for this philosophy, right? I read a lot of fiction related to non-fiction and fiction related to the end of life. And this is one of the topic, Dr. Nupur, which is very close to my heart. And in order to understand it, you have to live in their life. And when I was reading this book on Paul Kalanithi by When Breath Becomes Air, so this metaphor is like when you're taking a breath, right, you're alive. And when it becomes just like an air, you died. And he's basically a story of a neurosurgeon, that what he has experienced when he discovered in his active career that he's going to die. And if you read about the grudges, nothing was related to the physical pain. Nothing was related to anything less than the social, the spiritual, and the mental agony, which unfortunately has been left unaddressed for many decades. There's another book which you can always explore. This person is a Stanford professor. The last lecture, he had a pancreatic cancer. And with his beautiful life, which he was having along with the kids, the day he discovered that he's going to die, how he has been able to handle himself, the challenges, the mental agony, the physical challenges, the social challenges. This is all about exploring the second most important fundamental truth of your life, which is death. So basically, the heart of palliative care, which is also a part of your end-of-life care, indicates so many qualities which you will be requiring to have with you, apart from the technical aspects of treating the patients, like giving IV medications, giving them drugs, giving them opioids. You should be compassionate. You should be talking about the quality of life. You should learn how to communicate. You should talk about comfort and support. You should be patient-centric, and you should be giving a personalized care. You should not talk only about the physical comfort, but also the emotional, the empathy, and the spiritual. And majority of the things can be done by listening to them. Right? So almost we are in the end of the presentation. So end of life care doesn't mean the end of nursing care. I would like to repeat. And rather, it's a beginning of humanized, compassionate care, where all the disease terminates into the death, but human values and conduct wins the human existence. And this is where you, me, Dr. Nupur, Dr. Jitinder, and the ICCM Society is working. Before I close this presentation, I would like to ask from my fellow nurses. You can see there is a patient. He's almost a terminal disease. and you can see there are so many people who are doing the treatment for this patient. So what do you think is missing in this treatment or in this link? If you have any answers, anybody would like to speak? Nupur, if you can give them the permission.
Anyone would like to speak? Yes, I think we have Rakhi Rajput.
Yeah, Rakhi.
Unmuted you, please. Yes, Miss Rakhi.
Rakhi, you can unmute, please, yourself.
There's probably some issue.
No problem. Yeah, Rakhi, if in case, if you want to answer even through the message, it's perfectly okay. You can type your message. We can see. What do you think? You have to unmute, Rakhi. You can see that there is a red. Yeah, now it is right, Rakhi. Please tell me, Rakhi.
Yes, attendees.
Sorry?
Like you.
Yeah. Tell me, Rakhi, you want to take an attempt? What is missing in this treatment group? Which person is missing for whom we are taking this session? So you have a patient, you have machines, you have, the chief of the intensive care. There are 2 fellow doctors, and the third is a junior resident. Which one is missing? Nurse, right? So this is what we wanted to highlight.
We have a few answers in the chat box.
Yeah, please. Yes. Can you read them, Dr. Nupur?
Yes. So we have the answer from many of the nurses, and yes, they did identify that the nurse is missing.
Very good, very good. So, that is where the power lies. And in fact, I'm thankful to Dr. Jitendra Sharma that through this, this 30, 40 minutes of talk, I understand and I discovered my blind spots, my weaknesses. Because, unless and until you include the nurses into this composite, compassionate based care, the outcome is just physical. And that is where we're lacking, right? So the most important thing which we are seeking is the nurse, patient, and the family relationship. And that's why you plays a very beautiful role in not just the pharmacological treatment, the physical part, but also balancing the energy, the yin and yang of being a human being. You take care of their thoughts and you provide them love, care, affection, which cannot be given by any other human being to the extent what you can go. So with this, I would like to close my presentation. Thank you. Thank you, Hare Krishna. So that is what, I wanted to share regarding the end of life care, Dr. Nupur. Thank you.
Thank you, Dr. Manish. It's such an informative and insightful presentation. I'm sure when our nurses now return to the bedside, they'll have a more empathetic and more practical approach to end of life care patients. So since we have a few minutes left, let us discuss about some scenarios which we might often encounter with such patients in our ICUs. So one of the more common questions that we had were that one of the most important parameter in end of life care is to alleviate pain. Right. However, unfortunately, many times these patients, they are unable to communicate. They may be having a dementia, or they may be comatose, or they may not be able to convey properly about their level of pain. Right. So if any of the nurses would like to volunteer to answer, do we know of any pain scales that we can use in such patients? How would you assess pain in such a patient who's not able to communicate properly? Any of the nurses would like to answer?
They can put it in the group if they know any scale.
Add it in the chat. You can name any scales. I'm sure all of us
So I think that is very, very important point, Dr. Nupur, which you have asked, that unless and until you know what is the problem, how can you treat the problem? And for that, they need to understand whether my patient is having a pain, which is one of the most important physical aspect of the end of life care, which we have to take into the consideration. So I think we don't have any volunteers, maybe Raki. So maybe you can help them in, yeah.
So we have a number of scales which are there for this. In our hospitals, we usually have these scales enumerated and displayed in our bedside. Many of them are Wong-Boker scales, which are based on the grimacing and the facial parameters of the patient. For example, if he's grimacing or not, how is his body habitus? These are some of the scales. Then we also have behavioral pain scales. You can also have pain dementia scales. There are specific scales which are used in dementia patients. Most of these scales, they take the facial grimacing, the contour of the patient, and the way in which he's flexing his limbs as an indicator of pain. So you must go through these pain scales to be able to judge if your patient is having a pain or not. That is only when you'll be able to alleviate his pain properly in end of life care. Right. Now coming to the spiritual aspect. So many a times you will encounter that the relatives, they come to your ICU and they ask for some spiritual needs that they have. For example, maybe say lighting a candle or asking to get some
holy water.
Yeah, holy water. So how do you get along with these things? Do you allow it? Many times your hospital will not have that policy of allowing it. So what do you do in such a situation? How do you tackle the situation? Anyone would like to attempt? What do you do normally? This is a very common situation. Every now and then we do encounter this situation. So how do you go about it?
Anyone who would like to answer? It's an interactive discussion, guys. You nurses, the most important thing which you should learn that you need to have your voice. We need to hear you. And that is where your effective communication. It's not right now, we are not asking you to just listen. That is an important component, but right now we want you to participate. Yeah.
And just how you normally deal with the situation, that's right. You can come up with that. There is no right or wrong in that. Maybe you can exchange your ideas.
Any answers in the chat box?
No, we do not have any answers.
Okay. So, Dr. Nupur,
we have one of the answers. They said that we give them normal water. I'm assuming instead of holy water. So, I think, sir, please, you were saying something.
No, I think, see, one thing we have to understand, there are certain aspects of medicine which has not been addressed. So we are very good when it comes to the, the physical aspects of the medicine, as we have been discussing in the last 40 minutes, that we know the disease is there, disease को हमें treat करना है, but जो ये mental agony है, social aspects हैं, spiritual aspects हैं, ठीक है, जो ये thought process हैं, which are equally responsible for the suffering and the pain in the patient, also need to be addressed simultaneously. What I feel, Dr. Nupur, there are certain glitches we have in the policies which has never been addressed, because unless and until, like you have identified, that these are the potential, I would say, the differences which will come between the physician, the practitioner, the family, and maybe the administration, whether we should give them or should not give them. But having said so, I don't find any reason not to do it. Yes. For example, the person who's going to die, you have already accepted that this person is not going to be entitled for a curative treatment. In that situation, as we said, the spiritual support, the chaplain support, the support from the social circle, they plays a very important. In fact, Dr. Nupur, I was just going through the data when it comes to the end of life care, and I saw many of the people, they even have requested for the pets in the hospital. So their own pet, when they cuddle with the pet, right, if they are having a dog, or let's say they have a cat, or even the horse, you won't believe, I can share this video with you. So even with that, they feel much more connected, much more relaxed. Their pain scores go down. I'm not asking that tomorrow you should be having a horse or a pet or, or a cat in your hospital to take care of them. What I'm trying to make everybody understand, that please be open-minded. And it's time for us to redraft these policies, especially if they are not going to harm to your patient.
think we should try to accommodate as much as we can.
Accommodate, yes. Accommodate.
Maybe there are some things, for example, your candles, you
Right.
cannot light them. Maybe you can find alternatives.
Yes.
Make some electronic
Yes.
candles, something.
Yes.
Okay.
Definitely.
And one
definitely.
last scenario I would just like to ask. So the other day we had this patient. He was for end of life care. However, the patient denied for a dialysis. But the relatives, they insisted that we want our patient to undergo dialysis since the patient is not competent enough to make a decision for himself. We reiterated that no, your patient is competent enough. However, the family was insistent on getting the dialysis done for this patient. So any ideas of how to circumvent this situation?
Very difficult. I think Dr. Nupur, less than the nurses, I think it's going to be a challenge even for the best of the physicians.
Yes,
so, but important point is that, what I feel that when you draw this question, it's going to validate that what the patient needs. So one is you, or the second is me, or maybe the nurses. So the nurses plays a very important foundational role in validating that what do my patient needs. The reason why I'm saying, because it is basically the nurses who spend the maximum time with these patients. So they understand their patient to the best, especially their physical needs, their emotional needs, and whether they are sane or insane during this process. Now, it's not easy for me to understand whether the patient was cognitively right enough to take the decision or not. But in case if I feel on the basis of the inputs, let's say from you, from the nurses, and from majority of the team members, that the patient had a wish not to be stretched onto the dialysis, but the family is going against our wish. So maybe it's time for us to have an open, honest communication between us and the family.
Yes. Exactly.
At this stage, Dr. Nupur, it is very difficult for us to betray the decision of the family, because by no means you can prove it unless and until you have had the advance directive from the patient or their next of kin, right? So I would say the best way to circumvent or to come out from this kind of ethically challenging situation is to have an open, honest communication. Yes.
Absolutely.
So there's no right or wrong answer, because as we said, as long as the decision is morally justified,
yes,
which we were talking about non-maleficence. So if it is morally justified on the basis of the nurse says, okay, no, this patient has been having some degree of encephalopathy, may not be the right decision, and there's no advance directive from the patient and the family, by all the means of interaction, they are also the well-wisher for the given patient, then you should consider the decision in favor of them.
Right, sir. Thank you. So I would just like to tell you one important thing here, that around 8 or 10 years back, we had a paper where the quality of dying was compared within 40 countries. India was amongst those, and the other countries that we compared it were like Tanzania, Kenya, not even the developing nations, not the developed nations. And unfortunately, India was the 40th in this quality of dying ranking. So the quality of dying in our country is poorest.
Is worst. And do you know why, Dr. Nupur? What is the reason?
Again, sir, our awareness, one of them.
One is awareness.
We do not let go. That concept of giving treatment till the end, exploring all the options and not having that acceptance of...
Agree. True. You have basically nailed the coffin, the last nail. So unless and until we accept that the death is an inevitable process. Now, when we are saying that the person is going to die, we are not submitting to a failure. Rather, we are submitting to the acceptance of the fact that everybody has to die. And the disease has been investigated thoroughly, that it's a terminal disease. So we are not saying that it's an act of omission that the person is dying. It's an act of honesty, which we have done in case, and then it becomes easy for us to take that, the rightful decision. And another aspect which I feel, Dr. Nupur, in India, especially in our, the setups which we have seen, people are extremely talented when it comes to the technical skills of the treatment. which means the people, they know how to chew, ventilate, they know how to put IV catheters, the Foley's and everything. So we are extraordinary when it comes to the technical aspects of the medicine. But somewhere, unfortunately, the non-technical aspects has never been flavored, savored. They have never been nurtured, which I feel is a time for us to address.
True, sir. So we would like to end the seminar here. And
Right.
we just, if I summarize, and dying with dignity is a right of every patient. And end of life care, you should remember, it is not treatment oriented, it is comfort oriented.
Comfort oriented,
Please
yes.
do remember these 2 points, and hopefully we'll be able to better deal with our patients.
Thank you, Dr. Nupur. You are already having a challenge at your home.
Yes.
Your kids are after you. So,
Yes.
but thank you for giving your time, Dr. Nupur. I love this session, especially you as a moderator. And my utmost thanks to ISCCM for giving me this opportunity to embark on the new enthralling topic, which I feel is going to be the need in the next decade, at least, which I can see. So thank you. Thank you. Hare Krishna.
Thank you, sir. Thank you so much. Thank you.